Welcome, nursing students, to Discussions with Dr. G. I'm your host, Dr. G, and I'm going to take you on a crash course in diabetes meds, because if the pancreas won't do its job, someone has to. Today we tackle the hormonal chaos that is diabetes mellitus, where blood sugar either acts like it's on a roller coaster or has gone completely rogue. Your job is to keep it in check without accidentally inducing a coma. No pressure, though. All right, let's kick things off with the OG of diabetes management, insulin. Because sometimes your pancreas just throws in the towel and you've got to step in with a syringe. Now, as a nursing student, you've probably already had some nightmares about mixing up your insulins. And for good reason. There's rapid acting, short acting, intermediate, long acting, each one with their own quirks, and if you get them wrong, let's just say your patient's blood sugar could go on that roller coaster ride that they didn't sign up for. So let's start with rapid acting first. Think insulin Lispro or Humalog. This stuff is like the Sprinter of insulins. It kicks in around 15 minutes, peaks in about an hour, and is gone in 3 to 6 hours. You give it right before a meal, and if your patient decides to skip the meal because they're not hungry, you'd better be ready for the shaky, sweaty hypoglycemia drama. Seriously, always make sure they eat. Then there's the short-acting, regular insulin, Humulin R. This one's a bit more predictable, and it's the only insulin you can give by IV, which is why it's your go-to for diabetic ketoacidosis. Onset, 30 to 60 minutes. Peaks, 2 to 4 hours, and can last up to 10. Remember, give it 30 to 60 minutes before meals, and keep an eye on potassium. This stuff can drop it. Intermediate acting. This is your NPH or Humulin N. It's cloudy, but don't shake it like a protein shake. Just roll it gently. It covers insulin needs between meals and overnight, with an onset of 1 to 2 hours, peaking at somewhere between 4 and 12, and it can last for up to 18 hours. It is not for emergencies, guys, and if you're mixing it with regular insulin, remember, clear before cloudy, or the nursing gods will weep. And finally, long-acting insulin glargine or Lantus. This is your 24-hour basal coverage. It takes about an hour to kick in, has no peak, just a nice, steady background. Give it at the same time every day, and whatever you do, do not mix it with anything else, ever. I mean it. Know your insulins, double-check your vials, and if you're not sure, please ask, because the difference between a smooth shift and a code blue can be one cloudy vial. All right, moving on from needles to pills, because not everyone's ready for the daily jab. Oral anti-diabetics are a whole other circus. Let's break down the main acts, though. Sulfonylureas, biguanides, glitazones, and a few more. Sulfonylureas, like glipizide, basically squeeze the pancreas to pump out more insulin. Take it 30 minutes before meals, but watch out for hypoglycemia, weight gain, and weirdly, photosensitivity. Oh, and if your patient has a sulfa allergy or likes to party with alcohol, this is not their med, unless they enjoy vomiting and flushing. Meglitinides, like repaglinide, are similar but shorter acting. The rule here is eat within 30 minutes of taking it. And if you do skip a meal, skip the dose. No double dosing unless you want to see what hypoglycemia looks like up close. Biguanides, metformin. It's the star here. It's the only one. It decreases glucose production in the liver and makes your body more sensitive to the insulin it is producing. It's usually first-line medication, but it's not all sunshine and rainbows. GI upset is common, and there's a rare but deadly risk of lactic acidosis. So here's the kicker. If your patient's got renal issues or is about to get IV contrast, you need to hold the metformin for 48 hours before and after. I had a patient who was on metformin and got sent for a CT with contrast, and no one told him to stop the med. And well, let's just say we spent a lot more time monitoring his kidneys. Nurses, always check for contrast dye orders. glitazones like pioglitazone increase insulin sensitivity, but it can also cause fluid retention and even heart failure. If your patient has CHF, it's going to be a hard no. Monitor for edema, weight gain, and keep an eye on liver function. Then there's the rest. Alpha-glucosidase inhibitors like acarbose, they slow carb absorption, but brings the gift of gas and diarrhea. DPP-4 inhibitors like sitagliptin can cause pancreatitis, so watch for abdominal pain and vomiting. SGL2 inhibitors like canagliflozin make you pee out glucose, but it also increases the risk of UTIs and yeast infections. Hydration and hygiene matter here. Trust me. The bottom line, each oral med has its own timing, side effects, and safety pearls. If you don't know the contraindications, you're playing with fire. And always, always check renal and liver functions before you start or continue these meds. Now let's talk about the new kids on the block. Non-insulin injectables, GLP-1 receptor agonists like exenatide and amylin mimetics like pramlintide. These are great for patients who need more than just insulin or pills. GLP-1s slow gastric emptying, stimulate insulin, suppress glucagon, and bonus, help with weight loss. Just don't give them after a meal, and watch for pancreatitis and dehydration. A quick note about exenatide. It comes in a short-acting, which you may know as Byetta, injected BID or twice a day before each main meal. Other GLP-1s include semaglutide or Ozempic, also known as Wegovy, and liraglutide or Victoza and Saxenda. Tirzepatide, known more commonly as Mounjaro and Zepbound, and of course, dulaglutide or Trulicity. A nice-to-know slice of information as new nurses is that Wegovy, Saxenda, and Zepbound are the trade names used for the weight loss dosing of these medications. Ozempic, Victoza, and Mounjaro are the trade names used most commonly for diabetic dosing. Semaglutide also comes in an oral formulation for use in diabetes. The trade name, Ribelsis, and dulaglutide or Trulicity does not have a separate trade name for weight loss dosing. All right, amylin mimetics. They slow gastric emptying and suppress glucagon, but you never mix them with insulin. Give them before meals, and reduce the mealtime insulin dose when starting, or you'll be chasing hypoglycemia all shift. And then there's glucagon, the blood sugar replacement. The name can be remembered by thinking my patient's glucose is gone. If your patient is unconscious from hypoglycemia, this is your go-to. Give it IM, IV, or sub-Q, and then roll them on their side because vomiting is almost guaranteed. Once they're awake, follow with oral glucose, or you'll be right back where you started. If your patient is conscious, you can try juice or glucose tabs, which are chewable, or a glucose gel, which resembles cake frosting. The rule called the rule of 15s. This is used anytime your conscious diabetic patient's blood sugar drops below 70. You're going to give 15 grams of carbohydrates. That's a 4-ounce juice, 4 glucose tabs, 1 tube of glucose gel, or even a tablespoon of honey. Then you're going to recheck your patient's glucose in 15 minutes. Repeat the 15 grams of carbs and rechecking every 15 minutes until the blood sugar is over 70 milligrams per deciliter. The key here is to use sugar, fast-acting sugar, to raise the blood glucose levels. Once the blood sugar is over 70, you want to give the patient a protein like mixed nuts or a handful of jerky, or protein and complex carb combo like peanut butter crackers or a ham sandwich with a bit of extra ham. This helps to keep the blood sugar up, but steady. No blood sugar roller coaster rides if we can help it, guys. So that's the whirlwind tour of diabetes meds. Whether you're juggling insulin, orals, or injectables. It's all about timing, safety, and knowing your patient. Next time, we'll dig even deeper into the wild world of endocrine pharmacology. Until then, keep your vials straight and your snacks handy.